All right, soft tissue neck. It's a great elective if you guys can grab it. Ideally, we ask that you do a 2-view and not just a 1-view for it as a comp. But why would we do a soft tissue neck? And often it's for something called stridor, which is actually essentially noisy breathing. They might have a barking cough or hoarseness. There might be swelling in certain areas, a swollen epiglottis, which is epiglottitis. It's rare and pretty dangerous. There could be swelling in the tissues around the vocal cords, or what we call croup. It can help diagnose an infection in the area behind the throat, which was potentially an abscess behind. We can look for signs of enlarged tonsils and adenoids. Usually, almost often, that's on kids mainly. They might have difficulty with sleep. They might be having snoring problems. It could be recurring sinus issues or ear infections, something like that. It can also reveal a mass in the neck. It could be a cyst or a tumor or a foreign object that might be in there, a foreign body. Maybe something was inhaled or swallowed by accident or on purpose. That might be in the neck or airway as well. So do me a favor, go back and review respiratory system. What's the purpose? What are the divisions? I'd like you to know your anatomy of this area here, especially the parts of the pharynx. Okay, know that one as well. Again, here's another anatomy picture for you. The respiratory system, the trachea. What is the trachea? What is its role? Review that for me. Our routine at our clinical site for adults is a 2-view unless the order requests that it's a lateral only. Then we'll do lateral by itself. But if it doesn't say that, if it just says soft tissue neck, then you're going to do a lateral. Almost exactly the same as a lateral C-spine. You're going to be at 72 inches. You want the nose or the level of the nose in the light field. You don't need light in front of the nose, especially if they have a really big nose. You just need essentially the start of the airway is what they're looking for. And I'll show you that in lab. And then the AP is 40 inches, 8 by 10, just like C-spine. You're going to raise their chin up. Some of your texts use a 15-degree cephalad angle, just like C-spine. That is not textbook, and we're looking for air fluid level. But when in Rome, you do what your texts do. Breathing instructions are the key part of this study, and it's really important that you discuss them with your patient and let them know what they're going to need to do. You're going to ask them to take a slow, deep breath in through the nose. As they're doing that, you're going to make the exposure ideally on the full inspiration. That's your goal. And try to ask them not to raise their shoulders up when they're taking that deep breath in or move around. If they can hold still, do slow, deep breath in through the nose. Not a quick one, and you'll miss it in time, but a nice, slow one. Pediatric, it'll depend on how old they are. If they can stand, and the key is and hold still, depending on what their age is, you can do an AP and a lateral just like adults. Infants or toddlers who obviously can't stand and hold still, you're going to do a supine AP and a cross table lateral. You can use tabletop techniques for those. One of my key hints for infants and toddlers, they take a nice big inspiration right after they scream. So they're screaming, screaming, screaming. They stop for a second. They do a big inhale. So if you can time it right after the scream, you'll get a nice full airway. Textbook centering is C6, C7, which is super low. Our radiologists like to see the airway up here. So we do, and I apologize, this should be a C4, but just like C-spine. So they want to see the nasal passage right here where the nose would be. We do not go all the way down here into the chest for our clinical site, but you always have to know textbook for boards and textbook for tests. So know your textbook centering, but put a note in your clinical notebook what you need to do. Ideally, you want to see an air-filled trachea. Sorry, jumping over myself. This was just an anatomy picture. This is demonstrating here the epiglottitis or the swelling here in the anatomy. Here's an example of soft tissue neck on an infant. You can see that they've propped their chest up a little bit and the head is dropped back. You want to do that. Babies have like no neck. So if you could get this chin up a little higher to open this airway space, that would be key. There's a lot to hold on an infant like this. You need to hold their skull in lateral position. They're pulling their shoulders down to try and get the shoulders away from the neck. And it looks like they're utilizing a cassette holder here, which is great. They have a non-grid cassette, and then you try and get it right after the scream. I promise you'll get a nice airway. AP, upper airway, center ray at T1, T2. Again, that's textbook. That's not what you'll do at clinical, but for tests and boards, you need to know central ray textbook. Clinical, we do it just like C-spine. We do C4. Same breathing instructions. Slow, deep breath in through the nose. Looking for a nice open airway here. Open airway here. Here's an enlarged epiglottis. You can see that here. Look at this right here. That can't be good. See this bulge right here? That's pushing the black. So remember, black is air. This soft tissue area here is constricting this airway, and that's what it's doing. Foreign bodies. So this artifact here, this looks like a ring of some sort. This looks like a child has swallowed this. It might be a fishbone here. Coins. Kids love to swallow coins. As long as it goes down the right way, it might not get stuck, or depending on how big it is. So watch for that. We do a lot for coins. And that's it for